pleasure today to introduce one of our own, one of our family members, one of our previous fellows who has made good, and today we'll talk about new concepts in osteoarthritis, an area we don't talk enough about, a lot of wonderful things happening. Let me tell you a little bit about John Beery III. John Beery went to Notre Dame, graduated Harvard Medical School, did his house officer training at Johns Hopkins, and did his fellowship training in rheumatology here at Hospital for Special Surgery. He actually was the founding editor of the Manual of Rheumatologic and Outpatient Orthopedic Disorders, which is in its 4th edition. Many of you in the audience have it and use it. John is presently the medical director of arthritis research at Procter & Gamble Pharmaceuticals, and prior to that was at the Pharmaceutical Research and Manufacture of America, where he was responsible for clinical development and regulatory affairs. He has spearheaded a very large trial through his position at Procter & Gamble, now focusing on osteoarthritis, and I think it's an extraordinary time in rheumatology because not only do we have very important medications for some of the systemic inflammatory diseases such as rheumatoid arthritis, but we're actually talking about disease modification in osteoarthritis, the most common cause of arthritis that affects all of us at one time or another. And today he'll talk about some of these concepts, and if any of you haven't seen the Annals of Internal Medicine this past week, where Dave Felsen and his group have focused on the importance of the bone as a significant component of this disorder of osteoarthritis, I recommend that to you. John, it's always a pleasure having you back here. We look forward to hearing what you have to say.
Okay, so today I'm going to review the role of bone in OA, look at current imaging methods used in randomized controlled clinical trials. We'll look at it from a disease perspective, an organ, a tissue, and a cell. Just to orient you, the normal joint space in the knee is 4 to 6 millimeters, and that becomes a key number for clinical trial work. If you have more than 4 millimeters in a 2-year period, you're not likely to see adequate progression to make observations. If you have less than 2 millimeters, you're moving toward bone on bone, and a pharmacologic intervention isn't likely to be successful. By way of background, there's been some attention in the past to bone. The Caldron-Lawrence scale, after all, uses osteophytes and subchondral sclerosis as part of the definition. Eric Radin from Mass General, Wayne State, worked in this area for a number of years. He was more focused on the 1 millimeter subchondral plate, though, than the 5 to 10 centimeters on either side of the joint space that we're looking at now. At P&G, Dave Francis, who some of you may know, who was involved in the invention of the bone scan back in 68, 70, as a result of doing research. They were trying to find something to prevent premature tooth loss, and they found these bisphosphonate compounds did a great job making strong jawbone, but unfortunately they didn't do much in making teeth anchor better, so they set off on a series of investigations that led to Paget's technologies and a major interest in bisphosphonates at P&G. But David did the first Hartley guinea pig model work back in '88 that confirmed an OA efficacy signal, which set us off on this work. NIH had an excellent conference in 1994 that looked at the multifactorial dimension of OA, and you can find a brief write of this in the ACR primer in the OA article pulls together and gives the reference. But they made points that mechanical factors, biological factors, and this notion of the joint as an organ disease, and OA really being a condition where the organ fails. They also emphasized that, which is a key notion, there's an uncoupling of the normal balance of synthesis and degradation in key tissues, and both the soft tissue and the hard tissue is affected. In terms of the disease concept, I've already mentioned the anatomy. In terms of function, knees and hips have a role in their weight-bearing joints as shock absorbers, if you will, and they're affected by a number of factors. Is there a pointer here? Okay, well, all right. A number of factors listed there, and also invites one to think about the wolf lines, that the joint is able to adjust to new stresses and forces and align trabeculae along these lines that are most easily seen in a cross-section of a hip. Physiology, I've mentioned the local nature of this disease versus the systemic nature of osteoporosis, and that scintigraphy is predictive of where OA is going to progress, and that MRI is generating more data now as well. Just to remind you about the Caldron-Lawrence scale and the bony features of that as you see progression. This is a qualitative sort of scale, so it's limited in regard to making precise measurements over the typical time you're looking at knee OA progression. The hip is still tricky to study longitudinally. It's a curved surface, you get what the physicists call partial volume effects and so forth, so there's still some work to do before, and there's also more knee OA. It's a more accessible organ to image. In '96, both the FDA and the CPMP, which is the medical part of the European FDA equivalent, started to examine the question of what would be needed to guide investigators who would want to do longitudinal studies of OA. And at that time, clinical trial metrics were starting to be feasible. Chris Buckland-Wright, an anatomist in London, who's also an experimental radiologist, really pioneered this area. He did cadaver studies. He put contrast in knees and very precisely measured the soft tissues in the knee, and basically gathered the basic information to let this area proceed. He got accuracy data, precision data, variation data, all of which you must have if you're going to calculate a sample size. And then once you plug in an effect size estimation that you might get from animal data, you can calculate a sample size, design a study, and conduct it. The first knee structure study really was Ken Brandt's, started in 1997, sponsored by NIH. He used obese women, studied both the incident knee, or signal knee as we call it, and he's also making observations on the other knee to see if something can be detected there, using doxycycline, which, as you know, has some modest MMP inhibition properties. And this study's fully enrolled, and data should start to appear in the next 18 months, 2 years, something of that nature. The radioanatomic positioning is absolutely key. So these are the factors that really held up the early efforts to do longitudinal studies of OA. The X-ray beam alignment is crucial. Magnification, which you can put a little BB over the fibular head and control for that. Technician training, The study of which special surgery is one of our centers is using the Buckland-Wright fluoro-assisted method, so you know exactly where the knee is positioned, and more importantly, you can position it again in the same way at year 1 and year 2. If you don't do that, you get noise and variation. And then you must have a good QC process for these images, both for scientific needs and regulatory needs. In regard to the different ways to image knees, you have these, the standing extended knee. We don't walk around with our knees extended. When you have the knees extended, you have the anterior part of the knee bones touching. This, I'll remind you, was the technique used for the glucosamine studies in Europe. So there's so much noise and variation. At least when we looked at it, we really couldn't size a study. Ken Brandt looked at it, couldn't use it. NIH in the GATE study, they're doing a glucosamine study in their alternative medicines division, used the Buckland-Wright technique. They could not afford to do fluoro, so they accepted a little more variation. But in the Buckland-Wright, it's like you're walking. It's about 7 degrees of knee flexion, so it's physiologic, proper anatomic relationship. And that's this one here. That's the one the NIH is using. And if you want to get rid of some more noise, you can use fluoro positioning, repositioning to do that. There's another view that's been used, the tunnel view, Schuss view, named after the skiing position. And that's about 15 degrees of flexion. That's been used in a few studies. It's a bit variable, and there's a good paper by Fred Wolf and Chris Buckland-Wright comparing 100 patients with Schuss standing extended and this MTP view with 7 degrees flexion, as is this. That MTP is so named because of using the MTP joint in the foot to line up the position as you're taking the x-ray. So it's a way to do it without using fluoro, which requires a lot of training. Finally, there's a microfocal x-ray technique, and there are only a couple of tubes in the world active now. I'm using them in a proof of concept study on another molecule. This microfocal technique gives resolution of about 40 microns. It's almost histologic. They were used to x-ray nuclear warheads, critical submarine parts, things where you absolutely positively hope they're not going to fail, and so radiographing those circuits was important. But it was then applied to medical use and uses the same 7-degree flexion and then use of fluoro if you desire. And here's the reference of Chris and Fred Wolf in this 99 study, and basically showed the story of the comparative variation I just described to you. There's also epidemiologic evidence of bone involvement in OA. We'll talk in more detail about the Nevitt study about estrogen therapy and decreased hip OA. I'm starting to see some articles on decreased knee OA from the Felsen group. McAlendon, who's in Felsen's group, studied the low vitamin D state and noticed increased knee OA. In regard to the Nevitt study, looked at a cohort of 4,300 women. 853 of them had radiographic hip OA. 42% of them also had osteoporosis. And in the literature, there's this thing from over a decade ago where if you get osteoporosis, you never get OA. Makes no sense. I mean, basically, when people were doing BMDs, they weren't taking into account you. In the back, you get osteophytes, they're dense, it throws off your BMD measurements. So these are both huge disease. Lots of people have them. They really overlap a lot, and so quite a few people have both. That's what it boils down to. Anyway, current estrogen users have about a 40% decreased risk of any OA of the hip. And if you've been using estrogen longer than 2 years, you had a larger reduction in risk of hip OA. So some interesting bone active data out there. Now we'll drill into these perspectives. And I list these here because they lead themselves to various interventions, so they're kind of practical. Obviously, the weight loss is easier said than done for the aging boomers. Old biomaterials, muscles, you can exercise your quads. Ken Brandt and others have had some good data generated about that. And then, as we talked about, OA can be developed because of soft tissue problems or hard tissue problems. And then you have just regular old primary OA where it's mainly aging and weight issues. Looking now at bone as a tissue, we'll look at some scintigraphy data. I summarized Felson's paper briefly, and DEXA data, and some microfocal data. Felson's article just a few days ago looked at bone lesions on MRI and the association with knee OA pain. Called attention to the fact that cartilage has no innervation, so the pain has to come from other tissues, particularly the bone, and that you can see what are called these bone edema lesions on MRI, some of which I showed to you. He looked at 401 patients. They all had knee OA by diagnosis, by x-ray, including an osteophyte. So these were definitely people with OA and not just a sore knee. 351 of them had knee pain, and he had 50 in the study for comparison who did not. It was cross-sectional, studied with X-ray, MRI, and WOMAC, a standard assessment instrument to assess function and pain in the knee, and found that 78% of the painful knees had MRI bone lesions like those I showed you at the start of the talk. Paul Dieppe, in his 93 paper that I showed you images from, looked at 94 patients in a 5-year study. The endpoints were X-ray and scan at baseline and exit. As you saw, he had some selected samples of MRI, but they were not part of this big study. He had 120 knees that were evaluable at the end of the study. 22 of them went on to total knee replacement. 32 knees had a severe scan abnormality at entry, and 88% of these progressed to either knee replacement or loss of 2 millimeters of joint space. The 55 knees with no scan abnormality did not progress. Carvonen looked at sort of a poor man's version of an MRI. It was he set up a unique 3D BMD apparatus, and we'll talk a bit more about that. Buckland Wright, I'll call your attention to this paper using a microfocal technique where he showed that subchondral sclerosis and osteophytes could be seen before the joint space width was lost. So he was just signaling that you can see things in the bone before you can see things in the soft tissue. Carvonen at Wayne State in this 98 paper looked at 43 OA knees and corresponding number of controls. These were all female patients. Used this 3D DEXA scan which he divided the knee into segments and found that there was a 13% decreased BMD in the OA knees that he studied. He called out that there was no systemic osteoporosis in this particular group of patients, as he was trying to tease those things apart. And we mentioned some of the reasons. The older literature probably got that a bit mixed up. OA patients can either have normal or increased total BMD, and other studies, this one by Berger in '96, noted that osteoporosis patients have both a total and a local BMD problem. In other words, the BMD around the hip, which we measure assessing systemic osteoporosis, can be decreased. And Lee and Aspen looked at the bone plates in femoral heads and found decreased BMD in both diseases. Let's emphasize this is a complex set of problems, and call out some of this other data to help us appreciate that. At the Orthopedic Research Society in February, Ding from the Aarhus group in Denmark had this interesting poster noting the decreased quality of tibial cancellous bone in early human OA, and this interesting observation that the trabeculae became plate-like using micro-CT as his methodology versus rod-like in the controls. So you're just starting to see a lot of converging lines of evidence that support this notion of the importance of subchondral bone in OA. The cellular perspective is much more limited, and I hope to be able to talk to Dell and others around this institution about some approaches that might be taken to learn more about that. Carol Westacott in the UK has an in vitro system where bone cells from the tibial plateau will induce cartilage proteoglycan loss. Manicourt had this publication focused on osteoclast activity, noting that calcitonin reduces severity of cartilage lesions in a dog model and also has bone effects. I haven't seen this written about in a human study yet, but I'm keeping an eye on that in the literature. And they also looked at systems of synovial mediators in this paper as well. The data from the Manicourt paper are displayed here, and you see a drug effect for subcutaneous calcitonin in the femur and also in the tibia. The Pelletiers in Montreal are examining the biochemical regulation of bone and cartilage and looking at this IGF-1 protease system. So still a big story to be created there. We need to know a great deal more. Future research, the MRI story is still evolving. I looked at a big data set recently, and there's just too much noise to use it for a proof of concept study in the judgment of our group and our statisticians. I can imagine that some composite is going to evolve from here. I think you'll find a combination of cartilage volume changes and minimum joint space width. There'll be some kind of composite scoring system, because it's clearly going to be very useful. It's just too noisy right now. But it offers what you would like for chronic disease, some shorter study times and fewer subjects. It's semi-miraculous to get one of these things funded, and so you feel really, really good. After you go through all the hoops you have to get support. And it would be nice to have a more efficient tool. Markers are still too noisy. In our study, we're putting them in the freezer. If somebody validates one in the meantime, we can run whatever it is. At the end of the study, we can also take our best shot, because we're going to have the best data set of longitudinal neo anybody has in regards to the numbers and whatnot. But right now, you couldn't proactively call out a cartilage degradation marker or a bone degradation marker and hope to see anything useful. In terms of current status in this fairly novel field, cartilage-directed, I mentioned the doxycycline study that commenced in 97. I believe there are about 500 patients in that, very carefully done, about 6 NIH collaborating centers. The glucosamine NIH GATE study is very interesting. Interesting enough, I think they chose glucosamine hydrochloride, which makes perfect sense since our first chemistry course taught us if you put a salt in water, it gets ionized and everything floats off. So it shouldn't make a bit of difference whether it's glucosamine sulfate or glucosamine hydrochloride. But there are others who have different points of view about that. I mentioned the weakness of the X-ray methodology that was presented in the Lancet article. There are also some basic biochemistry issues about pharmacokinetics, etc. I mean, some are actually injecting the glucosamine in the joint to be sure it gets there. But the NIH will work that out, and by the end of that experience, we'll know what we can accept in that regard. Chondroitin, I think you can completely forget about. I mean, it's analogous to heparin. It comes from cow windpipe. Typically, I'm sure there are other places you can get it from. It certainly is broken into its components, and the chondrocyte is surrounded by all the glutamic acid and glucose it ever needs. So as long as there are chondrocytes there, the raw materials to make glucosamine and whatnot are certainly there. So there's some complex issues to watch, but this is a well-designed study, and we'll get high-quality info. There are some bone-directed experimental therapies I mentioned to you, and I think we ought to keep in mind that both bone and cartilage are likely to be affected by whatever is going on. There's cellular dialogue between bone and cartilage. These things are not happening in isolation, despite the cover picture on this month's A&R, which has just a big chunk of cartilage sitting on it with different MMP staying. Not the bone. Word bone isn't even mentioned in the article. It's but just interesting perspective. Okay. Summarizing, hopefully I've shown you some convincing evidence that NEOA is both a bone and cartilage problem, that bone is not just an inert stick on which the soft tissue sits. It's metabolically active, and there are scintigraphy data, MRI data supporting that. It's a very logical target for an intervention. We've looked at some of the anatomic and structural evidence for this with DEXA data, the microfocal data, bone changes precede the cartilage, and the epideme data, estrogen protective, low vitamin D state, a risk factor. I would note there's been slow acceptance of other things in medicine, although I kind of think bone and OA is on a bit of a roll now, helped along with articles like Felson's and whatnot. But the role of H. pylori and peptic ulcer, Barry Marshall, certainly didn't get a lot of acceptance until about 92 when the NIH conference nailed that story down in the literature. Bone and OA, and then 15 years ago, I sure wouldn't have. I thought it was way out thinking that you might have a therapeutic vaccine for rheumatoid arthritis and cancer, but now I also serve on the immunology licensing committee for P&G, and we're just getting absolutely fabulous proposals for things along this line, building on the genomics work that's been booming. So it really is a very exciting area in biology right now. This quote is a favorite of mine. Orville Wright died quietly in Dayton about 50 years ago, and Dayton is full of interesting aviation memorabilia. Some of you know I worked as a flight surgeon on Air Force One about 25 years ago, and really got hooked on aviation, started flying, which I don't anymore since my insurance agent doesn't permit it. But just if you're ever in the Dayton area and you can go to some of these terrific museums, if you have this interest, all the old Air Force Ones are in the museum now, including the plane we used in the 70s. They retired in there, but all the way back to Roosevelt with the first one, and the elevator for his handicaps and whatnot. But this is a great quote. If we worked on the assumption that what is accepted as true is really true, there would be little hope for advancement. Thank you very much, and be delighted to answer any questions.
John, I enjoyed that tremendously. You just touched on the issue of genomics at the end, and it strikes me that a topic that is still very live for thinking about is the fact that osteoarthritis in many cases is very familial. You'll see whole families where the disease appears at age 40 and others in which at age 80 they have virtually no osteoarthritis. That also brings into mind genetic errors in the components of both cartilage and bone that may lead to osteoarthritis. Obviously, that becomes, I think, less an open option for the pharmaceutical houses, but I'd like your thoughts on the genetic aspects of osteoarthritis.
Yeah, we view that as a very complicated area. There are some families where the genetics are pretty well described. We're probably in a disease like OA going to see a polygene story of some kind emerge. I haven't seen anything real focused and actionable from a clinical development perspective, which is the hat I'm wearing most of the time, and nothing in terms of licensing things I'm looking at that also seems just about to go somewhere. But whoever would have thought we would have had the genome sequenced by this period, and there's just so much information. The real challenge is trying to, I should say, so much data. The real challenge is trying to turn it into information. So it's going to be a very exciting area, but I guess at this point we figure there's enough of the regular OA out there to study, so we'll proceed in a more primitive way until that information arrives.
But the fact remains, Mike, genes don't work in a vacuum. And if in actuality you have the potential to make changes in weight, stresses, proprioception, and even some of the medications that John is using now might very well change the picture that is not totally preordained by the genes, but rather directed rather than ordained. John, I wanted to ask a question about the animal models with the use of residronate. Could you give us some idea upon that's the system upon which you based your study?
Sure. In fact, there'll be an abstract that we're going to submit to the fall meeting this year. So we'll have the data available in more detail. But basically, it's Alison Bendeley's guinea pig model that she developed while working at Lilly years ago, and she then went out to Colorado, where she is at the present time. Basically, these guinea pigs age and get heavy and get OA, and you can then take different interventions, which we did a number of, and see if the you can intervene compared to the controls. You have these animals in study for about a year. They show cartilage changes. They show some bone changes. And so that was the basis on which seeing drug activity. And lots of things work in animals and never work in people that you would then take it forward.
But it was disease modifying?
Yes, it was, and it was replicated.
John, I need to, the question I was going to ask before Steve's, I need to follow up both on what Michael said and what Steve asked. And one of those was my question. Really nice talk and great, and my pager is going off. In terms of Michael's question, Eric Radin got the Chance Award this year and gave an incredible talk, which I actually may get him to come back here and give, and talked about OA really being a mechanical problem with these genes affecting loading and structure. And I think that's very important. And so, yes, it's a complex trait, but the mechanics is what Eric has been stressing for a very long time. My real question, though, is there any evidence that risedronate or any of the other bisphosphonates has an effect on chondrocyte apoptosis as it does on intestinal cells and liver cells, as well as osteoclasts?
Yeah, I have not seen any evidence that it does, Adele. And this is an area I view as the area we need a lot more delving into. The cellular story is not as well developed as the imaging story, if you will. So going a bit in the reverse the way you do with many areas of research, but just the nature of this disease.
Well, just to keep Leon Sokolov's name in the story of osteoarthritis, the work on stress that he did with the engineering department out of Stony Brook is still a very important contribution to the issue of the mechanical aspects. But what I wanted to ask you is something quite different. The factors that influence the development of osteoarthritis are so varied: obesity, stress, activity, name it, plus maybe, as Mike said, certain genetic factors. How do you control any kind of a study, and how are you able to control the stature of patients, whether they're 6 foot or 5'10" or 5'6", as you go on to look at controlled populations? How is that possible?
Yeah. Well, we'll be able to stratify the patients regarding their BMI. And so essentially when you have so many different variables at work, your design is supposed to have enough patients in it that whoever has that unique combination of variables would be as equally likely to show up in the control group as the experimental group. But BMI is how we'll be able to stratify the height, weight part of it, but their occupations and...
You ask them all the same question: you never played baseball for the Mets or the Yanks or something like that?
Well, yeah, in the medical history we do try to sort out the jackhammer operators. And,
it's pretty hard stuff, though, you have to admit.
No, yeah, you're right. You're right, and those are important issues.
And there's an associated question there. That is, if you were to simply X-ray everybody by whatever imaging device you want, and then ask them about their complaints, do you think you'd find a good correlation between what the image shows and what they complain about?
Not necessary, and that's because OA pain is like a sine wave over time. The structural problem is there constantly, but the pain isn't. People have different coping skills. Pain is a very complicated area to assess, and I appreciate that more and more as time goes on.
And in Felson's study, they did not show a correlation.
Right.
Between them.
The severity.
Could you give us Peter, could I hear your response to this discussion?
Well, there's so many things to discuss, and it's very difficult to know where to start. I mean, Caldron and Lawrence showed that there was no correlation between the anatomical features in the x-rays they took and the pain. And one of the problems with the joint space is that initially, when you saw a joint space, I think that initially people didn't even make the correlation that that space might be occupied, at least in some part, by cartilage. Once they got that concept that it was cartilage that occupied that space, then they assumed that a reduction in the space must mean a loss of cartilage. And that if there was no reduction in the space, there could be no loss of cartilage. But actually, and then, so we did a little experiment a long time ago where we cut all the cartilage off a femoral head, except for around the rim, and we cut all the cartilage off the acetabulum. And we clamped the joint surfaces together and x-rayed it, and the measurement was exactly the same as it was before. So there was no cartilage on most of the femoral head, and yet the joint space measured the same. So that you could follow the joint space, and it looks fine, and if you dissect the joint, you will find there's no cartilage perhaps on the acetabular roof, because it requires more than a loss of cartilage. It requires a change in the entire geometry of the joint to alter the joint space. So there are all these sorts of things. I mean, I think you covered the ground remarkably well this morning, and particularly with regard to the therapeutic interventions, because the therapeutic interventions have to come in so many different ways. And one of our biggest problems is that when we see a patient with osteoarthritis, in most cases we have no idea what the particular etiology in that case was.
Right. That happened. The initiating event was so long ago.
Yes, because it happened 30 years ago.
Yeah.
John, your comment as to why osteoarthritis can be so asymmetrical sometimes. One hip can be terrible. Why osteoarthritis can be so asymmetrical. One joint can be, like a hip can be terrible, the other one perfectly normal. Why habited nodes are a typical finding. How do you put it all together?
It's an excellent question. Well, I think the Hebertin nodes are a genetic marker, and you can have insults that diffusely affect, and I'll just focus on the weight-bearing surface. I view these as markers, but on the weight-bearing surfaces, you could have gene defects that would diffusely affect the joints. You can also have something like RA that diffusely affects the cartilage, and you get premature DJD in there. But I think Peter's point was hitting on this, is that sometimes these initiating events are so far back there, the knee injury maybe you had in the soccer game as an adolescent and whatnot. So it heals up, you move on, and then 25 years later, your knee starts to hurt, but you wouldn't remember the man. Is that the?
Yes, and another thing, of course, is that as far as the lower limbs are concerned, most people have a slight difference in leg length, and a quarter of an inch difference in leg length over a lifetime has a profound effect upon your facet joints, which begin to give you problems, but also upon the knee and the hip. So when I found that out, I immediately put a lift in my shoe. I've always I wear a quarter of an inch lift in my shoe, and it makes a difference. And the person who pointed out that there was a problem was the tailor, because the tailor says to you, you know, this shoulder is always slightly lower, this hip is always slightly wider, and of course then if you have somebody looking your back, there's a slight, tiny curve on your spine. You put a quarter of an inch lift on and it's all straight down. The tailor no longer complains. And your back feels better. And probably you save yourself from getting osteoarthritis of your knee so badly.
Well, one more question for you, John. Since the ankle probably is one of the most weight-bearing joints per square inch. It's not the most common joint for osteoarthritis.
Right. That's a good point. Klaus Kuttner did those studies in Chicago where he got all these patients through autopsy and whatnot and found there was hardly any OA of the ankle. So the materials are the same, so it must be an exceedingly well designed joint, because as you point out, it's carrying all the weight that the knees and the hips are. Other than saying it's a design issue, I don't have any other insights. Anyone else in the audience?
Got 3 or 4 joints, not just one. Got more than one joint in that ankle. Mm-hmm. Maybe that has something.
Spreads out forces.
Well, the other interest, the same thing, is that in your elbow joint, you always have osteoarthritis at the radio-ulnar joint, even though you don't know it. But when you autopsy people, you will find that the radio-ulnar, not the radio-ulnar joint, the radio-humeral joint is arthritic, but the humeral-ulnar joint is not arthritic. And they have exactly the same synovial fluid. They're in the same joint cavity, but one part of the joint, the part with the rotary motion, but I'm not blaming the rotary motion, but the part with the rotary motion is always arthritic. The other half of the joint, which only has really this type of motion, mainly like the ankle, is not arthritic. Points to mechanical things.
Well, about that, a few years ago, I think Dr. Bullough saw an article from Australia, I think it was, where a group of people were studied during their regular life activities during the day, and somebody would walk around and say, okay, it's 15 minutes now, stop where you are, and meaning don't move. And they went around and measured all the angles of various accepted joints, or what joints they were going to study, on these various people for some 24-hour period. And they found that there was an interesting correlation, although not a very strong one, that the joints that were throughout the day used throughout most of their range of motion were the ones that were least likely to historically develop degenerative joint disease or osteoarthritis. Now, maybe that is useful in the ankle and in the elbow joint, the non-radial elbow joint, in the sense that there is so many limitations on the movement of the ankle that every time you use it, you're using it throughout its physical range of motion. So perhaps there is something to be said for that. And the knee, there's an awful lot of range of motion that we don't use in any kind of a weight-bearing sense throughout the day. So as a consequence, maybe there's some connection there. If you use it, you keep it. If you don't use it, you lose it. And there may be some sense there.
John, thank you very much.
Okay.